presentation with you all. Good morning, everyone. My name is Riva Pavel, and I am a research assistant in the PM3 lab under the supervision of Dr. Karche. My project evaluates the current AKI diagnosis epidemiological equations through literature-driven retrospective large data acquisition. To begin, what is AKI? AKI stands for acute kidney injury, and it is sometimes referred to as acute renal failure. AKI is diagnosed as a sudden episode of kidney failure or damage that impedes one's fluid balance and disrupts the kidney's regulation ability. AKI commonly occurs in ICU patients, more than 50% of patients, in fact, and its causes are either ischemic from prolonged hypotension or nephrotoxic from drugs like NSAIDs or diuretics. Damage is usually a result of decreased blood flow, direct kidney damage, or urinary tract blockage. AKI is extremely common and equally dangerous, as developing AKI usually leaves the patient at risk for developing other life-threatening health problems such as cardiovascular disease, stroke, or even developing AKI again. Some treatments can include hemodialysis until kidney function restores itself back to normal, increased fluid intake, and depending on the cause of AKI, some medicines may be stopped or prescribed. Initially, this study aimed to determine the relationship between hypovolemia and AKI. However, after reviewing massive amounts of literature, it was evident that AKI was not restricted to hypovolemia, and a broader view of the disease was required to truly account for its scope. Now, there are countless equations out there for evaluating kidney disease. In 1973, the Cockcroft-Gault formula was created and put into practice. This equation measured creatinine clearance from the body, which is one parameter used for estimating AKI. In 2009, the CKD-EPI equation was created, and it takes serum creatinine, age, and ethnicity into consideration when estimating glomerular filtration rate. The use of this equation is encouraged by the National Kidney Association. However, it is not yet perfect. For example, this equation only takes into account ethnicity if the patient is African American. Yet it is highly likely that Latina, Asian, Indigenous, and other ethnicities would require a modified equation as well. With the tendency of AKI to occur in critically ill patients, the prognosis for various diseases tends to falter after AKI incidence. As such, current equations need to be evaluated for their ability to accurately predict AKI. Over the next two slides, you'll be presented two graphical models comparing clinical data I found in literature and data estimated using the CKD-EPI equation. As you can see here, this is a graphical model that examines the relationship between mean serum creatinine and mean age in clinical data and using the equation. Clinical data is defined as the mean serum creatinine of patients diagnosed with AKI, and most patients represented here were ICU patients. The black circles here represent the clinical data, and the dotted line, as you can see here, is a positive trend of mean serum creatinine with increasing age. To assess the CKD-EPI equation's ability to predict AKI, the equation was rearranged to solve for serum creatinine. GFR was assumed to be at 40, 50, 60, and 70 milliliters per minute per 1.73 meters square, which were common values found in the literature, and as shown in the legend on the right-hand side here. And the family of curves is graphed along with the clinical data as represented by these colorful curves. Interestingly, the equation depicts a negative trend of mean serum creatinine with increasing age. This inconsistency between clinical data and the equation raises concern on the validity of this equation and its use in medicine. Now, this is another graphical model. However, over here, you can see that the relationship depicted is between mean GFR and mean serum creatinine. Once again, clinical data is defined as the mean GFR of patients diagnosed with AKI, and a lot of them were ICU patients. The black circles represent clinical data found in literature, and this dotted black line depicts a positive trend of mean GFR with increasing mean serum creatinine. In this model, the equation was manipulated for ages 35 to 85 in increments of 10 to determine values of GFR. This is depicted as the colorful lines, as you can see on the graph here. There are significantly fewer data points of GFR cited in the literature, as you can see the sparsity. Surprisingly, GFR was not commonly cited in the literature, despite it being the most common parameter used to estimate AKI currently in practice. Nonetheless, the trends are similar to the previous graph. the CKD-EPI equation depicts a negative trend, whereas the clinical data demonstrates a positive trend. As depicted on both graphs, the data is sparse, and it does not fit with what the equation is outputting. Both graphs reinforce the notion that the current epidemiological equations for assessing AKI may be inadequate for AKI diagnosis. That said, there are some limitations we need to consider with the analysis thus far. Not all literature studies cited data for serum creatinine and GFR. Thus, these data gaps reduce the generalizability of the study. As such, more literature would need to be studied and included to negate the effect of outliers. Secondly, due to the broad effect of AKI, patients were diagnosed with various other diseases such as HIV, septic shock, acute heart failure, etc. It is possible that the AKI parameters examined, like serum creatinine and GFR, were also affected by the incidence of these other diseases, and thus can act as a confounding variable. Nonetheless, this is ample evidence to motivate further research into the evaluation of AKI. The result of this project will eventually cultivate into an online software that will be able to predict the effectivity of AKI treatment following diagnosis. I have come across similar emerging technologies for ischemic stroke, as you can see on the right-hand side here, that provides statistical models for treatment effectivity. A similar program for AKI would be beneficial as well. Thank you so much for attending my presentation today. I hope you found it interesting and learned something new. I would like to open up the floor to any questions that you may have.
I have a couple questions.
Yes.
Hi, I can turn my video on, but it's Saturday, so I'm wearing a baseball hat, so forgive me. First, interesting, good presentation. Thank you. And this is kind of like, I come from more of an epi perspective. Mm-hmm. So predictive equations, the holy grail in medicine, right?
Yes.
Everybody wants a predictive equation. Everybody wants it right. So are you familiar with the Framingham risk score?
I am not, no.
Okay, so the Framingham risk score is the godfather, the grandparent, whatever, of all predictive risk equations, right? Mm-hmm. And that's that came from the Framingham study, Framingham, Massachusetts, 1960s, blah, blah, blah. And it predicts 5 and 10 year probability of cardiovascular disease, okay? Mm-hmm. And it is, so you can go online right now and there are all kinds of derivatives to the Framingham risk score. Mm-hmm. What's the challenge with developing any of these scores?
I would say that every individual is so different that one predictive equation is not representative of those different characteristics of, for example, different ethnicities or even different lived experiences have an impact as well. Yeah. So I think it is difficult, yeah.
Yeah, so okay, so those are error bars, right? Mm-hmm. But what kind of study design do you need to have in order to develop these predictive risk equations?
You would definitely need a very large sample of individuals that have these different characteristics to account for any outliers to come up with this.
You need a longitudinal study design, right? Mm-hmm. Okay, so you need to be following the same patients over a long period of time. I mean, that's why the Framingham study, for as flawed as it is, right? And what's the big glaring flaw now in 2021, looking back to 1960, when the Framingham study started, the big glaring flaw, Framingham, Massachusetts, a whole bunch of white guys, right? Like they didn't even enroll women and in the first kind of cohorts, right? Because that's just mm-hmm. how it was. So it was a very white study. Like that's just mm-hmm. what Framingham, Massachusetts was. And so all of our predictive equations around cardiovascular disease and who's going to get a heart attack and who's not going to have a heart attack has been developed with that cohort. Now, mm-hmm. there's probably arguably not a better source of data around cardiovascular disease in the world, at least in terms of a longitudinal study. they're now on the F3 generation. So they're now in the grandchildren generation. And you can imagine all of the genetic analyses that are going on with you know, kids, grandparents, and then the grandkids, right? But there have been lots of attempts in the US, particularly to do exactly what you said, right? There were no and in the US, the population is predominantly African American. So that's the language in the US. So there were no African Americans in those original risk equations and no Latinos. And so you can go into the literature and look for something called the pooled risk equation. So that has been the attempt to go back and adjust, right, the beta coefficients. That's what they need to adjust. They need to adjust the beta coefficients for different races, different ethnicities. So I have a question for you. If our goal is to have really as accurate as we can, risk predictions, right? So, okay, I'm going to back up one more second. So you need a longitudinal study design, which is the most expensive and difficult to do. Two, a lot of the times you're still talking about relatively rare events. All right. So relatively rare endpoint events, what does that do to your sample size?
Has to increase it.
Jacks it up. Okay. So you've got to follow a lot of people for a long period of time in order to really develop these accurate risk equations. So bring your money. So question though for you, do you think that we should be trying to develop a single risk prediction equation, or do you think we should be trying to develop stratified risk prediction equations?
Okay, so I think that I would be leaning towards the stratified one simply to account for how diverse everything is and how diverse the population is. I think in the past they have gone for the single equations, and as evident, it is not that effective in risk assessment. So I think in the new direction, a stratified approach is best to really account for the large demographics of people that require this use of this equation.
Yeah. So in the epi world, right? Are you talking about a confounder that you can adjust for, or are you talking about interaction where you actually need to go into stratification, right? And so anytime you then start to talk about stratification, that then functions as its own independent sample that you need. So bring your credit card and everybody else's credit card. All right. So
definitely.
Anyway, okay, I'll stop because I see that other people have questions, but good job.
Thank you so much for your question. I see that Dr. Frisbee here has 2 questions. I can read them out loud.
Just one, actually. One's it's a typo, so go ahead.
Oh, got it. Okay, so the one question. Why does the correction factor in the equation for Blacks, what does the correction factor in the equation for Blacks represent? Why is it there? So the correction factor, I could just share my screen and show the equation for just a visual aid here.
Sure.
And basically what it shows here is that if the patient is African American, then that 1.15 is multiplied to the equation to estimate for GFR. I believe they did some tests and they found that individuals who are African American had a higher GFR by 1.15, and that's why it's there. In the evaluation that I did, ethnicity was not commonly cited in the literature, so I did omit that from when I used the equation. So that is one thing to take into account. But yeah, that's what I would respond to that.
So what does that mean for predicting, let's just say, kidney health outcomes for Blacks?
I believe it just shows that, as the other Dr. Frisbee was saying, that there is a need for the stratification, because for the African Americans, there is a different or an additional requirement to get the GFR. It's not one single equation that's going to be able to account for everybody. And for African Americans, it shows that their GFR is higher as compared to, I guess, in this case, it would be Caucasians.
Okay, so which tends to predispose them to a poor health outcome.
Mm-hmm.
Correct?
Mm-hmm.
Do you know why it's there? Like what biologically does that represent?
Oh, I see. I have not looked into that yet.
Take a guess.
Oh, okay. If I had to guess,
I suggest you pick the simplest answer, Riva. Start with the simplest argument.
they may have a higher blood pressure, or
Well, almost. So what is the one characteristics that Blacks in the US share in terms of blood pressure? Almost overwhelmingly, almost unanimously, almost every one of them.
I don't know.
It's salt sensitive.
I see.
Okay. So most American Blacks have salt sensitive hypertension.
Okay. Yes,
Okay?
that
But
would
that's
definitely
not that most white folks, when they have hypertension, it's not salt sensitive.
Okay.
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 So I don't know how far, Sanjay, I don't know how far you want me to go with this. Do you know why? It is one of the single most amazing examples of artificial selection in the last 200 years.
Because
Or natural selection, I guess.
What their diet is more accustomed to
Sort
kind of appease that, or
So-
just the environment that they're in, the hotter climate.
So salt sensitive hypertension almost doesn't exist in Africa. It exists because when they were brought over as slaves 250 years ago, if you couldn't conserve salt at the level of your kidney, you weren't going to survive it. You were, whether it was the transportation, whether it was the intense physical labor, all of those things. So your kidney had to be an incredible salt conserver, or you just couldn't live. And so that like got passed on generation after generation after generation. And there's been amazing studies out of UCLA has torn this all apart, looking at genetic linkages and things like that. The salt sensitivity is through the roof. And it's because without it, you just die. So that keeps perpetuating itself down. And that's why you end up getting these correction factors in a lot of these equations, is because you have to account that, on a population level, their kidneys just function differently. So, the two greatest examples of that of the last, couple hundred years are that and eyesight. We're all wearing glasses. 200 years ago, we wouldn't be able to hunt. So we'd also just die. So, but anyway, nice presentation, but yeah, definitely interesting stuff.
Thank you. Thank you for your question.
Thank you, Riva. Excellent work. I'm looking forward to our next step. I also suggest everyone that we continue with our